Good evening and welcome to the urology mock viva sessions, and this is the 10th Uromet. And welcome all the our colleagues and today's examiners. I'm very thankful to Professor Neville Pereira and Dr. Nandasena kindly agreed to do the today's session. Actually, it was initially planned Professor Srinath and Dr. Ranga. Because of their personal commitment, we have changed the examiners. So today's session will be chaired by Neville sir and Nandasena sir, and their oncology session will be done by Professor Srinath and Dr. Ranga. So today is the first activity will be introducing the format of the viva. We all know it because we have done the MD exam part 2. So when compared to that, this exam won't be difficult. So I just introduce my experience and the format of the exam. So then if you have any question, then we can discuss. Then we'll move to the mock viva session. So Neville sir and Nandasena sir have already prepared 6 to 7 scenarios. So the plan is there are 6 volunteers. So one by one, 10 minutes case mock viva. During the mock viva, the examiner won't give any answers. Maybe they give some prompting. After 10 minutes, the session will finish and the examiners will give the feedback with the marks, and also they will give the answer for 5 minutes. Then again, the next examiner will ask a scenario from the different candidate. So that's a plan. So first we'll start with the introduction to the urology viva. Can you all see the screen?
Yes, we can see.
Okay. So so there will be 16 stations. So there will be the 8 table. So each table, there will be 2 examiners. So for example, the first table will be, let me control the mouse. Yeah, urological oncology. So that will have a kidney and bladder. Then oncology 2, prostate, testis or penis.
So
Then the other table will be pediatric urology. Then another table will be emergency urology. Then calculi and UTI, imaging and principles of urology, urotechnology.
Excuse me, Kobe, my slides are not moving. I think I don't know whether it is only for me.
Can you see this now?
Slides are not moving, Gobi.
only the first slide we can see.
Yeah, just wait. I
Go
will
to the slideshow. Yeah.
Can you see now?
Yes.
Yeah.
It's moving, sir? Moving?
Not moving.
To the presentation mode.
Okay, I think that.
If you can go to the slideshow on the toolbar.
Yeah. Okay.
And remove the presentation mode, because I think you are using 2 monitors. We can see only the first monitor. If you could go to the slideshow.
Yeah.
No, not that. On the toolbar. Home, insert, design, animation, and then slideshow. Yeah, click that.
Which one you want? From beginning?
No, click on use presentation view. Click that. next to down.
Can you see now?
1 second, slowly. Are you using 2 monitors, sir?
No, only one.
Then it has not run. Like the presentation is there without it's not running mode. I run the. Let me try to control it from here. Can you share it again, please? So for now, what you can do is just on the left side, you can just use the arrow keys to go down so that we will able to see the slides.
Can you see now?
No, just click on slide 1 here. I think the computer is stuck, sort of.
Okay. Yeah, can you see now? So I can move the slides.
But we are not able to see this.
Right, okay. Then what we do is without the slideshow, can you see that? Without the slideshow,
Yeah,
can you see it?
that is what you have to do. Yes. Now we
Yeah,
can
okay,
see.
fine. So I will increase the slides width here. Can you see the now?
Can see, yes.
Okay, right. So there will be 8 tables like this. So there will be 2 exams in each table. So they will ask, each table have a uro-oncology 1, uro-oncology 2. So you have to know which table you are in. That's a very important thing, right? So they won't ask any other questions, right? If you are in the kidney and bladder cancer station, they will ask about kidney and bladder cancer only. Then another table may be prostate or testis or penis. So they will ask, definitely they will ask prostate. Also, they might ask the testis or penile cancer. The next table will be pediatric urology. There will be 2 scenarios. So one exam will ask one scenario, other exam will ask other scenario. But both will give the marks for each scenarios. Again, emergency urology, 2 scenarios. Calculi and UTI, 2 scenarios. Imaging and technology, 2 scenarios. Bladder dysfunction, basically a neuro-urology and female urology, two scenarios. BPH 1 and andrology 1 scenario. So altogether you will go to the 8 tables, each tables 2 scenarios. So you will get a 16 scenarios, right? So usually this will happen in 4 sessions. That means you will go in, once you go in, you will go to 2 tables, then there will be 20 minutes break, then another 2 tables, 20 minutes break, then another 2 tables, 20 minute break. So then you will have to go to the exam hall maybe 4 times. The important thing I want to say is the marks are given in 3 domains. So one domain is professional capacity to and the patient care. So under that, your personal qualities, how you are ethics, so basically chapter on, are you concerned about consenting and things, and your surgical experience. When they ask a question, how you are talking about different surgical procedures, and they might ask, so when they progress in the question, close to the end, they will ask difficult question, or there are questions, there are no definite answer, gray areas. So how you are handling the stress and how you are handling the gray area. So that is so they will give a score out of 8. So the ideal, the pass marks is 6. Then they will give for the knowledge. So knowledge, how you are scientifically justifying your answer with the pathophysiology and the clinical reasoning. So knowledge and judgment, again, 8 out of, they will give the marks. Then the quality of your response, communication skills, and how you have organized your answer, whether you are just saying the answer, whether you have organized and presenting in a logical way. So these 3 domains, each domain, they will give a score out of 8. The bedside manner, of course, not for our urology exam, but for the FRCS general surgery, there are short cases and long cases. So for that, they have assigned. For us, all the cases are scenario based or computer based. So they give marks for these 3 domains. So 6 is a pass marks, 5 just fail, 4 is a clear fail, the 7 is a good pass, and 8 is a excellent pass. Now you have to remember, even if you get a 4 in a one station, you can compensate. That's an important thing, right? Because other examiner doesn't know about your performance. So marking scale from 4 to 8, the 6 is a pass marks. So now you are going to 16 stations and 2 examiners, and each examiner is going to give a marks for 3 variables. So the pass marks is 6. So 6 multiplied by 3 multiplied by 2 multiplied by 16. So that's 576. So your pass marks is 576, right? Somehow, one station you get 7, other station you get 5, you pass. So don't worry about not doing well in one station. Overall, if you get 576, you are pass, right? So the marking is based on the quality of your response. So we have to practice this. We have done this in MD part 2, so it's not difficult. But we have to practice this with the group discussion, not only one mock session. Now we have to practice again, right? So they are going to be the foreign examiners. They are going to assess our quality of Sri Lankan urology. So we have to practice this, otherwise difficult, right? And so with the time, difficulty of the question will increase. So you have to score better marks for that, right? At the start, they will ask open question. Okay, how will you assess? Don't spend much time in that question. No, you talk about history, exam, investigation, 5 minutes, then problem, because you have to progress. The more marks for the later questions. So the first question you structured and give the question answer very quickly, right? Then move to the other question, because first question, not much marks, right? The later question is going to give more marks. So they have to assess you are handling stress, handling the gray areas, and your operative ability. So you have to perform. This is kind of drama. So we had to progress. So first question always more or less same question. So you have to prepare how you are going to answer. And your answer must be clear answer with the confident and more prompting. If examiner asking, okay, what do you think? Giving clues, more clues, less marks. So less prompting should be there. So I told you we can cross compensate. So don't worry about not doing in one station badly. And examiners, they don't know about your performance, right? So just I have sent you the blueprint about the marking scheme, and just see how they give a good marks, 7 and 8, 7 and 8. So you will on the exam day you will get a time, your candidate timetable like this. So your station, so you can plan so which station you are going, so you can concentrate. Okay, I'm going to go to the kidney and bladder station, so question going to be kidney cancer and bladder cancer, so you can concentrate, right? Maybe we have to do some micro teaching. The candidates have to prepare micro teaching within yourself. You may have to organize a Zoom session, but what they do is in BAUS is each topic 5 minutes. The candidate have to prepare, and 4 minutes discussion and 1 minute changeover. 10 minutes Each day you can discuss about 10 small topics, right? Of course, now we don't have a time, but we have to do it. And actually, we have to organize a revision course. Bows organize a revision course, morning lectures, then evening mock vivas, then later 5 o'clock micro teaching, then lunch, so then dinner. So that's about 1 week full day session, and then they give marks and feedback. This time it's not possible, but we are doing a viva. Maybe next time maybe we can do in a better way. It is not easy. The exam is not easy, very stressful. We have to go not one revision course, multiple revision course. Each course very expensive, 1,000 to 2,000 pounds, right? But you will feel the difference when you are studying. Up to now, we may be managing with the limited differential diagnosis. Of course, 90% of the cases we can manage with the available skills and knowledge. But more we learn, you will feel the difference, and you become confident, and you will understand some difficult scenarios in a better way. So it's a tough job, right? So I was studying alone, away from family. It was in this was in the Leicester, difficult, but you will meet different people. This is Prof. Samim Khan. Is a BAUS, like our Anuruddha sir, BAUS academic committee chairperson. He coordinated all the courses, and he's well known for bladder cancer in UK. He has received so many awards from the Queen. And I told you it's very expensive. The rooms and the course itself expensive. So part 2 is not about knowledge. They are not going to assess your knowledge, because that is already tested in the part 1. Yes, they assess the knowledge one domain, but it's a game with the other components, right? Your skills, you had, practicing communication skills and things, right? So we have to practice. It's not going to be easy, but we can do, because we have done the MD part 2. That was a very difficult exam. So when compared to that, it's not that much difficult, but we have to practice, because at the moment we all are busy with hospital work and private sector, but we have to do it. You will feel the different. And always remember what station you are in. And examiners are most of the time correct. So don't try to correct the examiner. If they are not satisfied, just modify your, rephrase your answer and tell in a different way. And still, if you don't know, just say, sorry, I don't know, I can't remember now. Then you can move to the next question. If you stay there, you can't score marks, right? So the scenarios will be usually history, examination, investigation, treatment, complicate this way, but it can be, they can start in any point. So more marks for the complex questions, right? Please always mention about chaperone for a female patient and the consenting. So precise answer. 10 minutes will go like nothing. So don't spend time. Don't spend time in each question a lot, right? So quick response. And you have to show your colors within that 10 minutes. And if you don't know the answer, say, sorry, I can't remember. So once you remember, then you can say, I can remember now, and you can say it again. So time management is going to be important. Don't spend time in history examination, because less marks for history, more marks for your, because your knowledge is already checked in the part 1. So progression is very important and less prompting. So how to manage stress, and you had to say good morning, good afternoon, things for the examiner. You had to have eye contact with both examiner. These we all know that you had done in the part 2. And we had to avoid mannerism, like, showing the hands and things. Better thing is there will be pens and paper. If you have a difficult questions, you can show a drawing and explain, right? So please use the paper and pencils. That's important. And listen the scenario carefully, because sometimes we jump to the answer. Listen that, because there may be some important points. Patient was on warfarin, that kind of things. So listen the question. Patient with the Down syndrome. Listen that question. That is important, right? Then they might ask few pathology slides, like the prostate cancer gleason for CIS of the bladder, or seminoma, or clear cell RCC. Not everything. Balanitis cirrhotic obliterans. So those are the, I think, 5 slides they'll ask again and again. So if you just know those slides, because someday they will start from there. So what do you think? This is a histology you received from the pathologists. Because we are not pathologists, that's clearly yes, but we have to understand some basic pathology. They think that we have to know some basic pathology, right? So we had to know about slides, and we had to know about validated questionnaire. IPSS, of course, we all know. Like erection function, international index, we have to know. Then for incontinence, female incontinence, ICIQ. So we have to, there are few questionnaire we have to be knowing very well. So we have to know the validated questionnaires. Then landmark trials, of course, we are discussing about that. So we have to know about precision trial, protect trial, and SWAG trial. Sylvester, now if the bladder cancer, you get so many times you get the Sylvester trial. So for the intravesical mitomycin and BCGs, the Sylvester trial will, so many trials are there. So you had to know about that, and the latest Karna trials and things. So and they will ask about suspend trial and lower pole study, about lower pole stone, and VUR, pediatric VUR. They ask about this antibody prophylaxis plus surgery review trial, RAVUR review trial. So there are some landmark trials, not much. So you have to know that, right? They will, if you answer even, they will ask, okay, what is the trial you are supporting? Then the dress code, exam date, like a professional, how we go to the part 2, MD part 2. So it's going, it's a, if you pass this, you will get a different feeling. But it's very stressful exam. So in my experience, I'm going to the exam, but I didn't know that I have to book a train ticket. So I missed the train. Then I had to book with the expensive, when you are leaving outside the London, we had to book the train show, then the 3 days I have to stay in the hotel because we had to go early and adapt to the situation, leaving the family. It was not easy and not good meal. It was very stressful. Then once you did the exam, all your group mates. So I had a discussion group. Usually, the local trainees won't join with us because they expect they have their own discussion group. So we have to find Indian, Pakistan, and Egypt, and other people who are doing the exam. But most of them are locum consultant. So most of them are now passed. They are now robotic consultants. But it's difficult. But we can do it. Thank you, and good luck. But if you pass it, you will get a, you get a reward, and you will feel different. Thank you. Any question about this? Sorry for that. This screen slideshow is not coming in the screen. Anyone? Have any question you want to ask about this? Or Monipriya, you are okay?
Kobe, how are the gaps between the stations? Do we get to know how?
Yeah, usually you have to go to the 2 tables. That's mean each table is 20 minutes, 20 minutes. Then they will give a 20 minutes gap. But I don't know how it's going to be organized here. It's all depending on the exam hall arrangement and the availability of the examiner. But usually you will get about 20 minutes break between 2 tables. But the whole exam will be in 1 day. So you had to talk 160 minutes. You had to talk 160 minutes. Any other question?
And when you say about the pathology slides, do they mention that this is a slide from the prostate or like?
Yeah, basically, you know the station, right? Either prostate cancer or testis or penis.
Yeah. Okay.
So you know out of the 3 organs, or bladder or kidney.
Right.
right? So they will give a scenario. From that, you can get the idea. So for me, the pediatric urology, they said a child came with difficulty in passing urine and had a problem in the prepuce. And this was a histology. Then I know is a balanitis erotica obliterans. So, we can get a clue. So slides is nothing, just to get some your idea about this. But you can 90% time you know what is this slide. Right. So time is running up. So we will move to the mock viva. If you have any questions, we can discuss later. So we will start the first. So we have two examiners here, Professor Nabil Pereira and Dr. Nandasena, who is going to be volunteer the first exam. Is it Nalin is here? Nalin?
Yes, I'm here.
You want to start with the first exam?
Okay.
Right. So the first scenario will be asked by Professor Nabil Pereira. You have 10 minutes. When 10 minutes is over, I will give you a. I will tell you the time. Right. So time start now. Nalin and Nabil sir.
Good evening, sir.
Right. Good morning, and let me start by giving you this patient who is a 40-year-old man who was seen at the outpatient clinic following an episode of right urinary colic. And GP has arranged a plain X-ray of the KUB, which demonstrate bilateral loin opacity urine report, which reveals 10 RBCs per high-power field. Rest of the scan and clinical examination was unremarkable. Let me see whether I can show you these. Yeah, I think if you can, could you comment on this X-ray?
Yeah, this is a plain X-ray KUB of a male patient, and the obvious abnormality I see is there's bilateral hyperdense areas in the renal area. If I comment about the right side, there are multiple radio-opaque areas, mostly involving the upper pole of the kidney. And on the left side, the radio-opaque areas are mostly involving the lower pole of the kidney. So basically, this X-ray KUB shows bilateral renal calculi. And on the ureters, if I look into the ureters, I don't see any abnormalities in the ureter, except for on the right side, over the lower part of the ureter, there's a small area of radio-opacity, probably a lower ureteric calculus.
Okay, how sure are you about the side of this placement of this X-ray?
Sorry, sir, I couldn't get the question. Can you?
How sure are you about the placement of this X-ray? Thinking of the sides, you're mentioning right and left.
That is, I think it's a posterior anterior X-ray. I mean, most of the X-ray KUBs are posterior anterior.
Yes.
So I think there is a marking. I could see a marking over with a R, letter R. So
okay, can you see one? Yeah, okay, right, fine. Okay, yeah. Let's move. Let me come back to you. Okay, now, what are the further investigations and the information you are planning to gather prior to start treating this patient?
So in my initial clinical assessment, I will make get a focused history and a focused clinical examination, and then move on to basic investigations, including the midstream urine for full report, repeat full report, and midstream urine for culture ABSD as well. And then his blood panels would be run for renal functions tests, including serum creatinines and blood urea nitrogen levels. And then the basic serum creatinine level as well should be established. And apart from that, imaging wise, I would go for a ultrasound scan KUB to assess whether there's any features of obstruction and hydronephrosis and hydroreader. So based on that, I will decide on whether I need a non-contrast enhanced CT KUB to decide on the further management.
So you would do an ultrasound only, or ultrasound and a non-contrast CT? Both.
I'll initially do a ultrasound scan. That with that I will decide whether there's an obstructing calculus to see whether I need an emergency or urgent intervention. But anyways, if I'm planning for the further treatment or the long-term plan, I need to have an idea about the renal anatomy as well as the pelvic calyceal anatomy. For that, I would request for a basically.
What is the sensitivity of ultrasound scan and X-ray picking up a ureteric stone?
That is based on if it is a lower ureteric calculus, the sensitivity is less. But if I combine X-ray and ultrasound scan to determine an upper ureteric calculus, it has more than 90% sensitivity and specificity to pick up upper ureteric calculus. But here, what I suspect is a lower ureteric calculus on the right side. So based on the bladder status, whether it's filled bladder or not, the sensitivity might vary, and based on the
Can you put any figures onto that?
Sorry, sir, I do not have any exact figures.
So non-contrast CT, which we don't have the films, confirms 2.3 centimeter solitary lower polar stone in one kidney and 2.5 pelvic and 1 centimeter multiple upper calyceal calculi in other side. What are the treatment options available or you would recommend to this patient for this solitary stone?
So the 2.5 centimeter stone is in the lower pole.
Yeah.
2.3 stone is in the lower pole. So based on the evidence available, because it's 23 millimeters in size, the best option would be to go ahead with a percutaneous nephrolithotomy. But other options available would be retrograde intrarenal surgery, that is flexible ureteroscopic access to the lower pole. But it will take longer time to treat the stone, and the complication risks based on that, the longer duration of the surgery would not be very satisfactory. So based on the evidence, the best option would be to go ahead with a percutaneous nephrolithotomy.
Okay, so if the patient refuses anesthesia vehemently due to a bad experience during one of the past surgeries and requests shockwave lithotripsy, which he has heard that is non-invasive, how do you convince this patient?
That has to be assessed based on the information that I gather from the non-contrast enhanced CT. In that case, I would assess the density of the stone, the calyceopelvic angle, and the infundibular neck, the anatomy of the infundibular neck. If all these figures are satisfactory and favorable towards ESWL, and the patient is vehemently refusing any invasive procedure, ESWL can be considered. In that case, if the stone density is less than 1000 Hounsfield units, and if the infundibular pelvic angle is more than 70 degrees, and if the infundibular neck is less than 5 millimeters in length, and if the width of the infundibular neck is more than 5 millimeters, there's a favorable outcome. But considering that this is in the lower pole, the expulsion of the stone fragments would be, should have been enhanced by further measures like giving physiotherapy after the
Okay, well, let us come to that.
procedure.
Okay, what evidence is available to determine the best treatment between shockwave and PNL, that is percutaneous nephrolethotomy, for this type of a stone in the lower pole?
There are two studies which has compared the effectiveness of ESWL versus percutaneous nephrolithotomy and percutaneous nephrolithotomy plus versus retrograde intrarenal surgery based named lower pole study 1 and lower pole study 2. So lower pole study 1 compared ESWL versus percutaneous nephrolithotomy, and a lower pole study 2 compared lower pole percutaneous nephrolithotomy versus RIRL or retrograde intrarenal surgery.
Okay, so you mean to say that shockwave lithotripsy is not included in one of these studies?
It was, sir. The lower pole study 1 includes shockwave lithotripsy versus
Okay,
percutaneous
anything
nephrolithotomy.
now? These studies were done sometimes back, so they are now old. Any new studies going on?
I'm not quite
You
sure
heard about PO
that.
study? PO?
Not sure, sir.
Yeah, it's going on in, okay, fine. Right, so let us move on. Okay, so what are the contraindications strong contraindications to go ahead with shockwave lithotripsy?
There are patient-specific strong contraindications, like if the patient is having
Apart
any
from
evidence.
what we have already mentioned.
Yeah, if the patient is having any coagulopathy, or if the patient is having any evidence of aortic aneurysm, there's a strong contraindication for shockwave lithotripsy. And since this is a male patient, it does not apply.
Time's up. Time's up.
Okay.
Pregnancy is one of the strong contraindications.
Right. 10 minutes up. I think, as Balagobi said, it has run very fast. So, fine. Okay. Thank you very much.
Thank you, sir.
Neville, sir, you can give your feedback. So then we can do the 5 minutes.
Yeah, straight away. Actually, a lot more to go, but I think Nalin did fairly okay. Only thing is that I expected him to find that this X-ray is an unmarked X-ray. So always when you are looking for plain X-rays, look for the side, because that error can go up to the operating table. Though there is a little mark there on the right side, actually you have to look at the position of the kidney. So if you look at the kidney positions, the right one is high up there. It should be the other way around. So this may be a misplaced or malplaced or wrongly placed X-ray. So if you have mentioned that, I would have been happier. So and regarding the stones, it's okay. So his colleague was on the right side. So if the other side was the right side, then of course this opacity could have been. You should have told that this is an unusual shape of an for a ureteric stone. So it may be a calcified ligamento. We would try to entertain another differential diagnosis. And regarding your investigation part, I think the gold standard for a ureteric colic nowadays is straight away to go for ultrasound scan straight away, because this is proven beyond doubt and it's all in all guidelines. So I think best not to argue with the sort of try to balance the merits and demerits of ultrasound scan and X-ray combined compared to NCCT. NCCT is the standard investigation, and that will give all the information you need except the renal function. So that could have been the straightforward answer. Rest of it is all right, but you would have mentioned, I would have expected you to mention metabolic screening, because these multiple stones bilateral. And so I think after, if you mentioned that after stone analysis, I would definitely, at least after stone analysis, I would consider strongly metabolic analysis or metabolic screening. I'd be happier. And regarding the treatment modalities, I think you quite correctly decided to do the correct thing for a large lower calcium stone, which is the correct again, but is correct treatment. But if the patient or there are negative patient factors, adverse patient factors, or patient respiratory protest, as I was mentioning, the other two, other two possibilities, PNL and URS, you have to consider, but then you should be able to give the demerits of those in figures, like, you know, bad anatomical positions can affect the URS, the success rates of URS, and the PNL is an invasive procedure, but the evidence, I think you have to, when I asked for the evidence, what you said was right. Lower pole 1 is actually PNL and versus Shockwave Lithotripsy, but the lower pole 2 had Shockwave Lithotripsy still in its study group, and it was compared with flexible UR. The latest study is the PUR study, which is still going on, and they were supposed to get the final results in 2020. For some practical reasons, they have postponed the final result by another 18 months. So that is the biggest study, and it's a multicentric, a large study, and which will give throw some light. So better to know about this ongoing study in UK, because I'm sure they are all involved in that. There we have two contraindications. What you said was right. Then I think if you just rattle it off, saying too small, too big, you know, too hard, too soft, like you have learned in your MD part 2, that will be fine. So that is where we stopped actually, and there are a few more questions to go, but I will assess you on what you have, how you have performed during these 10 minutes. And do I have to give the assessment now itself? Out of 6, 7, 8?
Yeah.
Yeah, I would leave him at say around actually 6 or 7, because I'm putting all the facts together, not only his knowledge, but the way he was tackling things, considering everything. I think I will keep him at 7. Yeah.
Thank you,
So,
sir.
okay.
Yeah, and Nalin, one more thing. In the X-ray, you said hyperdense lesion. It should be radio opaque, because in X-ray we use radio opaque and radio lucent.
Yeah.
And the CT we use hyperdense and hypodense. In the ultrasound we use hyperechoic and hypoechoic, isoechoic, because sound. And MRI we use hyperintense and hypointense. So these words must be correct. Yeah. So you've done very well. So if you have said in that way, it will be very nice.
Yeah.
Right.
And
So,
can I ask a question, sir? Now, with regards to assessment of a patient with ureteric colic, the EUA guideline recommendation is to go ahead with the ultrasound scan. And if the information gathered in an ultrasound scan is not adequate, only to go for a NCCT. That is the 2021 guidelines, what it says.
Yeah.
Should
I think it is safe, as Prof said, Nalin, go ahead with the NCCT KUB, because minimal radiation dose, and you can read nice guidelines. It's recommend the NCCT KUB straight away.
Yeah.
And especially this patient, if you take, these are multiple stones. It's not only a ureteric stone. When it comes to multiple stones, you get more information if you straight away go for an uncontrasted CT, because anyway you are going to end up in an uncontrasted CT in this particular patient.
Yes.
Yeah.
Thank you, sir.
Nandasena sir, shall we move to the next scenario? Neville sir, can you stop the screen share?
Yeah. Okay. Sure. Just a second.
And who is next? Dr. Munipriya, you want to volunteer the next one? Yeah.
Sure.
Okay. So Nandasena sir and Dr. Munipriya, and I will share the screen once Neville sir is stop sharing it.
How am I going to?
Just close your screen, sir.
Just close the screen. All right.
Yeah. Fine.
Right.
Yes, sir. I hope that my screen won't cause any issue. Can you all see the screen?
Still not sharing.
Can you?
Yes.
Sir, Nandasena sir, you can start.
Good evening, sir.
Investigated for microscopic hematuria. I think he is seeing this patient and X-ray was done and it's fine. What do you see this X-ray?
Sorry, sir, I couldn't hear.
This is a 25-year-old healthy male. Can you hear me?
Yes, sir. Yes.
Yeah.
And investigated for microscopic hematuria. And GP has done an X-ray and referred to you. And what can you see this X-ray?
I can see one side of the kidney, including the few vertebral bodies, and the kidney pelvic aliceel system is shows radio opaque lesion, so Staghorn calculi. Staghorn calculi, because it's extending to the all the calyceal system as well as the pelvis, include the stone is encasing. So because of that, it's a Staghorn calculi. So commonest cause for Staghorn calculi is infection. Stone is the struvite stone that is due to most of the time urease producing organisms like Klebsiella, Proteus, and
This sort of question, what are the special considerations for the management of this patient?
First thing, I want to go through the history and examination, as well as then I want to find out the patient's renal functions, especially because this is a single side. I can see the single side kidney, but this patient may be having bilateral Staghorn calculi. So I want to see the patient's renal function, as well as I would like to see the differential function if the patients having single unilateral Staghorn calculi before the managing this patient, as well as I want to see the patient's symptoms. If it is a bilateral Staghorn calculi, I would decide which side is managing first, depend on the patient's symptoms.
Now, you can manage this patient. What is your final goal you want to achieve?
If it is a Staghorn calculi, the main problem is recurrent infection can cause the renal insufficiency, and according to certain studies shows the conservative management of Staghorn calculi cause more morbidities and mortalities, and in cadaveric studies there is a they have found more than 7 patients death due to the Staghorn calculi. That is stage 1 of that Staghorn calculi analysis. Then stage 2 they have done the retrospective analysis.
Shall we go to the next question? What irregular interventions? What are the options available to treat this stone?
The available options depend on patient's factors as well as available facilities available in the hospital, as well as the surgeon's experience. So It can be percutaneous nephrolithotomy with multiple track, multiple punctures, as well as open technique, the open pyelolithotomy and pyelonephrolithotomy. So,
Tell me what the operative investigations you would carry out before planning surgery for this patient.
this patient is 25 years. I think this patient is ASA1. So I am happy to carry on the percutaneous nephrolithotomy for this patient.
Any other investigations you carry out?
Before that, I want to do the urine culture and antibiotic sensitivity test to be done. And as I mentioned earlier, the differential function of the kidney as well, I want to know about that.
And to do culture, you get positive culture, and significant growth of microorganisms. What is your response to this situation?
If the patient's the culture positive and if it is a symptomatic, first I want to treat the infection, but with this staghorn calculi, we can't 100% we can't achieve the infection free status. So most probably we have to treat the patient with the acute infection and then go ahead with the surgery. And the other problem is as a differential diagnosis, it may be a xanthogranulomatosis pyelonephritis. That is a very serious problem.
So what position would you advocate? Which position would you prefer?
Position is left lateral position in table break-in at the jackknife position, and table is break-in at the level of iliac crest level.
What about prone and supine position?
If it is a supine position, I have to go through the transperitoneally. So it is a retroperitoneal approach to the kidney. If lateral, the loin approach to the kidney is better in this case rather than the transperitoneal.
What about prone position?
Sorry, sir?
What about prone position?
Prone position, the problem with the prone position, the complication of anesthesia related complication and the cardiovascular complication is much higher in prone position. So
The patient 25 years more.
Sorry, sir.
This patient is 25-year healthy male. No other comorbidity.
Is still the prone position, positioning of prone position have so many complication. Even we do the prone position PCNL, we have to attribute that complications. So musculoskeletal complications as well as the cardiovascular and those complications.
Right. At this patient, yes, calyceal extension to upper, mid, and lower pole.
Yes.
So, access which calyx you puncture to achieve maximum bone clearance.
As this as appearance of dilatation of this the system, I would puncture the lower calyx and try to achieve the maximum stone clearance. Failing that, I will do the second puncture.
What are the benefits of doing an upper pole puncture in this situation?
The benefit of I can't figure it out, sir.
Okay. So if you are doing a upper pole puncture, would you do supracostal or subcostal? Do you know the stone clearance and the complication rates in a Sturgeon calculus doing upper pole puncture?
Yes, when we do the upper pole puncture, there is a risk for the entering into the pleural cavity. So to minimize that, we will do Valsalva maneuver, and other thing is we can puncture the middle calyx and get the kidney lower down and do the intracostal puncture to the upper calyx, so we can minimize the thoracic complication of PCNL by puncturing the upper pole of the kidney.
We'll move to the next question. Now, when you're doing this puncture and when you put the guide wire, it doesn't go in and it gets stuck. How do you react to the situation?
Because of the Staghorn calculi, I expect difficulty of inserting the guide wire into the pelvis and the ureter. So in that situation, I would get into the puncture in the onto the stone of the lower pole.
Sir,
Okay.
time is up.
Right.
Sir, you can give the feedback.
Monopriya, your answers, I don't know, I feel not quite adequate in what you said. And also sometimes you go out of the question, something like that. I feel you are not directly answering the questions. Now, let me go through your definition of that first question is okay. I said what special considerations for the management. Now, what I want to answer is, so these patients have progressive renal deterioration, urosepsis, and large stone burden, which has to be managed properly.
Okay, sir.
What is your final goal? So in this patient, what we want is a total stone clearance with minimal morbidity. Surgical options, okay, PCNL, you said open surgery, PCNL plus RIRS, that's okay. Investigations are okay. And the position regarding this patient, now I asked which position would you prefer? Now in a Staghorn, the prone position is the best position because you have a very wide area. You can do multiple punctures. Your flank is fully open. You can do multiple punctures easily, but this is not like in a supine position. So your answer is not correct there. And I asked about what calyx is. And in a Staghorn, the upper calyceal puncture, if you can do, is the best puncture because you can access the ureter, pelvis, even the lower calyx, right? So
Okay,
coming
sir.
from top down is much easier than rather going from below up. So in
Okay,
this
sir.
section, I will do upper pole puncture. So what we want is to do the minimal punctures. The more punctures you do, the more morbidity is high.
Okay, sir.
So that is there you are wrong. So I asked you what about the benefits of upper pole puncture? So one is when you're doing upper pole puncture, your access is very good for the renal pelvis, lower calyx, and yeah, that's main reason. Then regarding supracostal and subcostal punctures, there are no much difference. Yeah, that's basically. So there are some deficiencies in this case you handle. So my marks would be somewhere around 5.
Okay, sir.
So you need to answer questions more. You have to understand the question and answer directly. And I think your knowledge also a little bit insufficient in this case.
Okay, sir. Thank you, sir.
Right. So we are moving to the third scenario. And the Dr. Nishantha Veerasinghe will meet Professor Neville Pereira. Neville sir, you can share your slide if you want. Nishantha, are you ready? Nishantha Veerasinghe.
Good evening, sir.
Good evening, Nishantha. Just give me a second. Share the slides. Screen. Yeah. Okay. Okay, Shanta. Good evening. May I present this patient to you? 20-year-old female presenting to the A&E with clinical features suggestive of left-sided ureteric colic. Clinically, she is at present afebrile with stable parameters and in some degree of pain, and abdominal examination was unremarkable. And how would you proceed with this patient? He's in the A&E.
I would like to get thorough history and examination of this patient and do basic investigations like urine full report cultures and full blood count and renal functions. And then considering this CT scan, the sites not mentioned, but usually this coronal section of CT scan is shown in from the when we see in the front view. So it is basically the left side kidney. I can see a stone in the upper ureter, lower part of the upper ureter, blocking with hydronephrosis and hydroureter with thinned out parenchyma.
So how would you define upper ureter?
Upper ureter is above the pelvic brim, sir. So I cannot exactly see the pelvic brim. It may be very close or just above.
Okay, right. Okay. Go on. Yeah. So now this is NCCT.
Yeah.
What now? If it is your preferred diagnostic tool for this type of situation, what are the benefits of doing a non-contrast CT over the other available investigations?
The benefits of non-contrast CT KUB in this type of patients is I can exactly identify the stone, their location, the sizes, and the Hounsfield unit, the density, and if there is any the high degree of hydronephrosis, and as well as if the patient don't have stones, then there will be it will be facilitate to diagnose any other possible diagnosis away outside of the genital tract.
Okay, right.
And
what is the place of doing? Sorry. What is the place of doing an ultrasound and X-ray KUB in this particular patient? In the end,
if they haven't done a CT scan, then the ultrasound and CT X-ray KUB is there is a place if there is a basic investigations available. So X-ray might show the stone sometimes, but it might overlap with the pelvic brim. Sometimes we might not see. The ultrasound will show only the hydronephrosis and the thin parenchyma and the presence of the other side kidney.
Okay. Picking up a stone, when it comes to picking up a ureteric stone, how would you compare non-contrast CT with ultrasound regarding sensitivity and specificity?
Sensitivity and specificity of ultrasound scan on picking up stones is ranging from 40 to 70%, But when considered in the non-contrast CTKB, its sensitivity and specificity are above 95, 99%.
With that information, what information will you not gather from a non-contrast CT?
Information what I not gather is the functional differential function of the kidneys and the function of the affected kidney.
Okay. Any other stones you can miss?
I can miss the indinavir stones. They are the drug stones. They are not visible on the CT scan.
Okay. So what will be your preferred management in this particular patient?
So in this particular patient, I would explain myself and the diagnosis and reassure the patient about the finding, and then need to give some analgesics as she is on having pain first of all, and then once the patient comfortable enough, I can explain the things and plan management to manage this patient.
Analgesics are you? Do you prefer what analgesics do you prefer?
I prefer non-steroidal anti-inflammatory drugs in this patient. That will reduce the degree of pain, and it also shown that it reduces the episode of pain recurring.
Okay. How do the non-steroid anti-inflammatory drugs act on a patient with ureteric stones?
Non-steroidal anti-inflammatory drugs act on the apparent arterioles, the constriction, and reduces the GFR and the pressure. And also it reduces the inflammation of the ureter and the pain.
Okay, right. What will be your next step? Once you have controlled the pain, what will be your next step?
Yeah, if the patient is adequate pain control, then I would need to assess for the definitive function. In this case, I can see very little amount of renal parenchyma left. So this may be a chronic obstruction and presenting acute pain. So I would like to assess the differential function of this kidney, and depending on the function, I would like to go for example, if the function is good, I would like to go for ureteroscopy with laser.
How would you know that the function is good?
I would like to do a differential function like DMS scan or DTPS scan to see whether the function is good.
Okay, this is an A&E setup, and how fast do you think you can get isotope scan done in this situation?
That of course won't be able to do it in the A&E setup.
Okay. So, are you planning to admit this patient?
If the patient is comfortable with the analgesics, I am not going to admit this patient because this is chronic obstruction and there is no sepsis, and the patient is under control with analgesic, provided the renal functions is also okay. I would routinely admit for the ureteroscopy and laser if the function is okay.
Okay. So this is what sort of an obstruction would you classify this as? Is it a total
chronic
partial?
More likely partial chronic obstruction or complete. I'm not 100% sure.
Okay.
Probably chronic complete
that...
obstruction. Sir?
Okay, complete obstruction. And if it is complete obstruction, how fast should you decompress this kidney? If you want to see renal function.
I should decompress this system as early as possible. Let's say the next available list.
Okay. So what is your preferred method of decompressing this kidney?
The decompression wise, there are two options, either retrograde stenting or antegrade percutaneous nephrostomy. Given this patient is having chronic obstruction and in a large stone, retrograde stenting might be failed. So if the facilities are available, percutaneous nephrostomy is ideal. But if it is not, I would go for retrograde stenting.
Okay, what are the merits and demerits of these two procedures?
The retrograde stenting is easily available because the urologist is done, and the percutaneous nephrostomy we have to has facilities and the radiologist to do, and the percutaneous nephrostomy can be done under local anesthetics, and that doesn't need any anesthesia. And there will be subsequent access to the renal upper tract through a guide wire, then it can be changed easily. But for the retrograde stenting, the patient need anesthesia, especially if the patient is unfit, then there will be a problem. The other thing is there on the retrograde access, there could be failure rates. There could be we may not be able to put the stent properly, and there could be injuries to the ureter. And percutaneous
assessing the differential function, what will be more beneficial? DJ stenting or PCN?
PCN would be beneficial because then we can directly measure the output from the
sir,
PCN.
time is up. Time is up.
Okay, right. So we'll stop here. Thank you, Nishanta.
Thank you, sir.
Okay. I think you managed most of it. It is a very straightforward question, but when it comes to a totally obstructed system like this, I think you should consider it as urgent, or at least, not an emergency. Even if it is not an emergency, semi-urgent. Especially if you have told that without knowing the function of the other side, I would try to save this kidney, because there is a fair bit of cortical tissue still left there. Because if it is less than 5 millimeters, then of course it may be non-functional, but without the rest of the films, we can't say that. So this type of situation, I think you should be kind of, your attitude should be more nephron sparing when it comes to it. Okay, so especially if I told that it's a diabetic female or a hypertensive, then so be it. And this regarding non-contrast CT, you manage well. And radiation doses, if somebody asks, compared to IVU and NCCT, you would have told that, earlier the practice was to do IVU, but NCCT gives most of the information with 3 millisievert exposure. So put your knowledge like that, and occasionally you can do in the lower aortic stones, you can do prone CT to find out when the stone is rolling down to the midline. And so I think you did fairly well, and your initial management, I think that the comparison of URS and PCN, I think the UK practice and practice anywhere now, I think decompression, percutaneous decompression is the first choice I think you should give, rather than subjecting her to a ureteroscopy and any intervention under general anesthesia. So I was expecting you to be more conservative in putting a PCN and then draining the kidney and see. I mean, there may be pus, as you know, that chronic pyonephrosis, there may not be any fever or anything. So we don't know what it is. So I think go for total obstruction, go for percutaneous decompression first, and then you would have start by telling that I would like to admit this patient because it's a total obstruction, because I don't want to take up any more delay in OPD surroundings, outpatient surroundings. So with that, your comparison between J-stent and PCN was quite good, but know the pros and cons. So I think I will place you somewhere in 7, 6 will be better. Yeah, I think you will move on if you have managed this with decompress the kidney to start with.
Yeah, thank you, sir.
Okay. Thank you, sir. We are moving to the fourth scenario. Who is the next volunteer? Dr. Hillary. Can you see this? Sorry. Can you see the screen?
Yeah, I can see the screen.
Yeah. Andasena sir, you can start.
Good evening, sir.
Sir, please unmute, sir. Yeah.
Can you hear me?
Yes, sir.
Yeah,
You can start.
Right.
Yeah.
This patient is a 55-year-old male who came with non-specific lower abdominal pain, and ultrasound was done, and he had bilateral hydronephrosis with low-lying kidneys and multiple stones filling all calyces. And there was a soft tissue bridging between the lower poles. Looking at this X-ray, what is your diagnosis?
This is a part of X-ray KUB, I reckon, and I can see the kidneys are more medially sort of arranged, and I can see some abnormally positioned ureters, like maybe some contrast is also used, maybe a part of a contrast study depicting a horseshoe kidney with calaceal.
Yeah, okay, Larry. What is the incidence of this sort of renal abnormality in your general practice, in our urological practice?
About 1 in 500.
Okay. What are the special considerations you should give to this sort of patient? What are the problems you encounter compared to a normal kidney?
Yeah, so the horseshoe kidney gets into arrest into a normal position because of the isthmus of the kidney is gets stuck in the inferior mesenteric artery region, and the normal rotation of the kidneys does not happen. So because of that, the calyceal anatomy is different to a normal kidney. The posterior calyces are more.
So what are the problems you encounter?
Yeah, the ureters are inserted more at a higher position. The drainage is not very good, and the stones clearance wise, it's going to be difficult, and the access is going to be difficult because of the insertion and the different anatomy, and the puncture.
What about the calculus stone formation in this sort of kidneys? Are they more common or less common?
They are more common because of these anatomical changes of the ureteric insertion and more dependent sort of calyces.
Right. Okay. Now, why stones are more common in horseshoe kidneys?
There is more urinary stasis in these dependent sort of calyces.
Yes.
And because of the higher ureteric insertion, the usual sort of expansion pathway is blocked. And also,
how do you know about metabolic abnormalities in these patients? Are they more common or the same?
I'm not 100% sure about that. I think they are a bit more common. I can't recall the percentages though.
Okay. So what are the common metabolic abnormalities you encounter in these patients?
The most common ones are the hypercalciuria and hypoxaluria sort of abnormalities. I'm not 100% sure.
Right. So now this patient has symptoms and he has stones in all three calyces. What other investigations would you carry out?
I would like to get the pelvic calyceal anatomy by a contrast study, maybe CT-IBU, that will give me more details about the directions of the calyces and how the stones are arranged within this pelvic systems in each side of the kidney, of this horseshoe kidney.
Any other investigation?
I'll also do a differential function to see whether the drainage is adequate as well, because I might have to combine with a drainage procedure, or maybe if the ureter is not draining properly.
Right. So what now, as a endourologist, what are the special abnormalities you would consider and you want to know about these horseshoe kidneys? In other words, what are the abnormalities in this kidney, which is important for you to know before, as an endourologist, before planning surgery?
Yeah. So I would request for the renal angiogram to know the vascular anatomy of this patient as well.
Why? Why?
Because if I have to combine either endopilotomy sort of a procedure, I need to know where the vessels are located in relation to the place where I'm going to put the incision, endopilotomy. And also that will give me an idea about if I'm planning on PCNL, that will also, the CT will also let me know about the anatomy of the colon in relation to the kidney as well. So then I can avoid accidental sort of, I can plan my tracks according to the anatomy there.
What do you know about the ureter of these patients?
The ureters are more, they insert to a higher position and more lateral sort of a position.
Calyceal anatomy?
The calyceal anatomy, the lower calyceal anatomy, the lower calyces are more posteriorly directed, and the upper calyces are more sort of laterally, posterolaterally sort of directed because of the abnormality of the rotation.
Right. Okay. What surgical procedure would you prefer to get a full stone clearance in a one renal unit?
Supposing that the whole of the radio opaque lesion is a stone, it's going to be challenging in either way, like even if you do the open or the percutaneous nephrolithotomy. But if you consider the stone clearance rate, probably the open surgery gives better option for stone clearance at one go.
What about PCNL and RIRS in this patient?
PCNL definitely has a place, and it's a very good option. RIRS is probably the last option I would use if there is no other, if the patient is not suitable for anything else, just to probably to clear the pelvis and to sort of like provide a drainage pathway for the urine. But other than that, I think I would like to know more details about these anatomy before I make the final decision whether open or PCNL. Definitely PCNL or the open surgery are going to be the two main options I'm going to use for these patients.
Right. If you are going to do PCNL, what is your positioning or how do you position this patient?
I'll do prone PCNL. Because that will give me a greater sort of access area and more freedom in puncturing into the preferred position. Now, it's going to be a bit tricky with PCNL because the kidney is not in the normal anatomical position. And therefore, I'd probably go more medial than in a normal puncture and more posteriorly. And I'll probably target the pelvic, the renal pelvis and the lower calyces. But it depends on how the contrast study showing me the anatomy of the kidney. I'll plan my puncture according to that.
If you do a PCNL and if you achieve a good stone clearance, do you use a stent in this patient or not?
I will definitely use a stent in this patient because it's a complex stone with large stone burden. And these sort of patients could have infective components. So there is a risk of post-operative complications with infections. So because of that, I'll definitely
time
use
time is up.
stent
Yeah.
or a tube.
Hilary, I think you did fairly okay, but there were some deficiencies in your knowledge. The diagnosis is correct, incidence is okay. And I asked what are the special considerations in this patient. So these kidneys are more prone to obstruction, infection, and calculi formation. And I asked you the reasons. One is stasis, other is they have more common metabolic abnormalities. And as you said, they were hypercalciuria, hyperoxaluria, that sort of thing. Then investigation, CT, DTP is okay. There I asked some, what are the implications of the anatomy to the endourologist? So there are a few anatomical abnormalities you encounter which are very relevant when you're planning either PCNL or RIRS. One is the long tortuous ureter, high insertion, you said there may be, yeah. Then as you said, the calyceal anatomy is distorted and they are more posteriorly. And there are abnormal vessels, and yeah, that's correct. And surgical procedure-wise, I think the PCNL is the best option in these patients in a prone position where you can access, but there are limitations of RIRS because the high ureter attached in the top and coming down to get a full clearance because there are all calyces are full of stones. And I ask you whether we put a stent. Yes, always better to put a, because this ureters are abnormal and kinked and you might get post-op urine leak. So your answer is correct. So I would put you on 6.
Okay, so thank you, sir.
Thank you, sir. And maybe you have to mention about they need a long sheath and a long nephroscope.
Yeah.
And usually they prefer the upper calyces because upper calyces will be very lower.
Yeah.
And right. Thank you, sir. Then we are moving to the 5th case.
Thank you.
The Dr. Nisantha Lianapatrana, can you please volunteer?
Yes.
Neville
hi.
sir is ready with the next question.
Okay.
Neville sir, you can share the screen.
Graph. In this case, it will be just questioning. Good evening, Nishantha. And
good evening, sir.
Let me give you this case scenario. A 42-year-old man referred to the outpatient clinic, your outpatient clinic, with episodes of dysuria and painful ejaculation over last 1 to 2 years, episodic, and irritative LUTs, again episodic, and negative urinalysis in most of occasions, and except one positive culture, and he's otherwise healthy and was treated with empirical antibiotics on several occasions by the GP. So what are the, how would you interrogate this patient to find out what's going on?
Yes, so
what are the salient facts you?
Yes, I would take a chaperone-assisted focused clinical history. So I would look for the presenting symptoms, mainly considering whether it's sort of what sort of dysuria And then considering the duration of the time of the symptoms, and also as any other associated lower tract symptoms, including storage and voiding symptoms. At the same time, I would ask for a red flag symptoms like hematuria and recurrent, well, he has had one culture positive infection. And also back pain or severe back pain suggestive of any significant prostate, advanced prostate cancer. And we'll quickly take a sexual history, whether there's any erectile dysfunctions. And then if the patient's having significant LUTs, I would go for a questionnaire, IPSS questionnaire and assessment.
Okay.
The differential, yeah.
Anything else? Yeah. What differential diagnosis is running through your mind?
And yeah, sorry, yeah. So I would consider my first concern of this 42-year-old man with recurrent symptoms. I would be concerned about the chronic prostatitis or chronic pelvic pain syndrome. Those are my two differential diagnoses. And at the same time, I would like to exclude any stone disease or any genitourinary TB, including TB prostate or tuberculosis of the bladder, and also a possibility of current UTI with significant lower tract symptoms due to benign prostate hyperplasia.
Okay. In case the history and examination are non-informative, none of these salient features are positive, how do you further investigate? And which differential diagnosis will come top in the list?
Again, chronic prostatitis is the first differential diagnosis. And then I would like to exclude any prostate cancer. And then I would like to consider genitourinary TB as well as stone disease as differential diagnosis.
Okay. All right. Okay. So suppose, sorry, I lost the connection, I think.
No, sir, we can hear you.
We can hear you, sir.
Just let me get back to the.
Sure.
Oh, here we are. That's right. Okay. Sorry about that. Okay. So, what sort of now say that let us say the urine analysis and radiography is all negative. So, so you entertain the diagnosis of chronic prostatitis, you said. How can you objectively assess this situation? Objectively, how bad the situation is?
Yeah, I think there are two ways which we can assess. One is the chronic prostatitis symptom score analysis. So it is a validated questionnaire to sort of objectively categorize the symptoms, and then to come to a diagnosis, we can do a 4-glass test, which can sort of differentiate between categories of prostatitis.
Good. Is it chronic prostatitis symptom index? So what sort of features do you assess in this symptom index? To mention few.
Dysuria. I'm sorry, sir. I'm not.
Oh, okay. That's right. So, so what is the underlying now? Suppose you are suspecting clinically strongly that this is chronic pelvic, chronic prostatitis. What is the underlying pathophysiology of it? Now, this is, you said something about the chronic pelvic pain syndrome as well. So, what is the underlying pathophysiology of chronic pelvic pain syndrome?
Yes, the exact pathophysiology or the etiology is not very well known, but there are a couple of postulations, and possibly there are a few things. One is the low-grade infection, which is ongoing and triggering the sort of symptoms. Second one is neuron-mediated inflammation, like secreting various neuroactive peptides. Then some people describe it as a the muscular condition, or a muscular with a painful or muscular trigger points. Those are the few sort of postulated mechanisms.
Okay. Do you have any specific investigations to confirm it as chronic prostatitis? Because chronic pelvic pain syndrome is not chronic prostatitis. So are there any investigations you can do to pinpoint
investigations recommended is the 4-glass test. So we can assess 4 specimens, that is namely VB1, which is the initial 30 to 40 ml of urine, which assess the prostate, the urethral urine culture and a smear, and then VB2 is the sort of like a midstream urine from the bladder. And then the EPS, which is the prostate, a brief 30-second prostate massage, and then sort of excreted or extracted secretions from the prostate. And then VB3, which is the afterwards the voiding sample, which is again coming from the prostate. You can send them for the culture as well as the smear test to find out.
I may interrupt you. Exactly how do you do that? How do you get the prosthetic massage done when you're doing this test? You take the first, you said that you take the first 2 samples.
Yes. And then do a 30-second prostate massage, and then trying to.
What is the position of the patient when you are doing the prosthetic massage?
You can do a knee chest position, and then we can sort of do a finger massage of prostate, both lateral lobes.
Okay. Right.
And then squeeze the milk, the urethra to extract.
Right. So how do you classify chronic prostatitis?
Chronic prostatitis can be classified into 4 categories. One is the category 1 of the type 1 is the chronic bacterial prostatitis. Type 2 is the type 1 is the acute bacterial prostatitis. Type 2 is the chronic bacterial prostatitis, and type 3 is the type 3 can be divided into 3-1 and 3. 3-1 and 3-2. 3-1 is the sort of chronic abacterial inflammatory prostatitis, and 3B is the chronic non-inflammatory abacterial prostatitis.
Can you tell me how you would manage this patient? The basic guidelines of managing this patient.
Yeah, so I would first I would like to discuss the diagnosis with the patient with the given history. Most probable diagnosis would be chronic pelvic pain syndrome or chronic prostatitis. So I would like to explain the nature of the disease and the chronicity of the disease, and about the realistic expectation of the outcome of the treatment, which is going to be a recurring condition, and which we might not have a sort of exact treatment option to completely cure it. And so that's one aspect of my treatment planning. The next aspect is to sort of see whether he's got any other sort of phenotypical categories of.
Time is up. Thank you.
Okay, right. So thank you, Nishanta.
Thank you, sir.
Well, I think Nishanta did fairly well. So this is an area which is vague to everybody. So I think you knew about you asked about salient facts you would like to highlight in the history. You mentioned most of it, like Lutz and excluding stricture disease, stone disease, pneumaturia. One thing is the diverticulosis and pneumaturia to check whether there's diverticulosis and recurrent infections, and tuberculosis, as you said, and the long stay in Middle East and living Middle East, excluding schistosomiasis. So, diagnosis-wise, I think we agree that it is chronic pelvic pain syndrome with prostatitis. So you have mentioned about the prostatitis symptom score and the clinical features. I don't think you have to know it, but at least few questions out of the questionnaire will show that you have at least gone through it once, or you have just you are practically using it. So when it comes to a patient, so like pain or discomfort, you give certain figures, numbers, and so like that. So just know a few things about it. And pathophysiology wise, you mentioned a couple of causes. They are all theories, as you said. That is quite right. Chemical irritation, and then immunological causes are also mentioned, and then intraprostatic reflux, and neuromuscular causes, and chemical irritation. So STEMI test, and then the modification of STEMI is now being practiced, called Nichols test. Nichols is, I think his name is everywhere in chronic prostatitis. Nichols test is just taking the pre and post prosthetic massage urine samples. And what they have shown is that it's almost gives the same diagnostic value as STEMI for glass test, Nichols test. And I just asked a bit of a practical question, because whether just to see whether you have actually gone into the details of it. I mean, what they do is now they just ask the patient to bend forward, hold the couch, and then give the prosthetic massage while standing. First glass, second glass, bend forward, hold the couch, and you give a good massage, and then get the secretions and the post-secretion, post-massage sample. So I was just about to ask about phenotypes of chronic pelvic pain syndrome, but the time ran against it. So I think you have done fairly well in that case. So I would give you, say, even 8, because all the questions were asked. You did very well. So
thank you, sir.
Thank you, sir. Hopefully, we are moving to the last scenario. Dr. Suranga, can you please volunteer? And Dr. Andasena sir will ask the question. I will share the screen.
Good evening, sir.
Good evening, Suranga. So this patient is a 70-year-old obese female with multiple comorbidities, and he had a mitral valve replacement and is on anticoagulants.
Can you, Dr. Suranga, can you see the screen?
Yes. It's actually.
Yeah.
Yeah.
Okay, right. Sir, carry on, sir.
You got the history?
Yeah.
Suranga?
In the halfway, sir.
This patient is 70-year-old obese female with multiple comorbidities and past history of mitral valve replacement, and is on anticoagulants. And he had a right side renal colic, and scan and ultrasound was done, and there is a 2 centimeter renal pelvic calculus, and he has persistent pain. Can you describe what you see in this X-ray, and can you put other X-ray also, contrast study?
This is the plain X-ray KUB, yeah. And with poor bowel preparation, but I can see the right side pelvic renal stones. I would like to see the non-contrast CT KUB before planning further treatment option. At the same time, I'll go through the proper history and examination with the chaperone and with the verbal consent before getting overall picture.
All right. So investigations wise, what would you like to do? A contrast CT or non-contrast CT?
I think apart from the basic investigation like UFR and urine culture, I will do a renal function as well, because of the she has multiple comorbidities. And then I think it is better to have a non-contrast CTKB first. I think probably she's with a renal failure as well. It is a gold standard test nowadays, and we can get most of the information we have to get for a plan for any future intervention.
Okay, now this patient's serum creatinine is normal, and if you do a non-contrast, he has a 1,200 Hounsfield unit stone with 2 centimeter calculus. So how do we proceed from there?
Actually, I consider about her comorbidities. It's a multiple mitral valve replacement with anticoagulation, and when you consider about the non-contrast CT-KUB, the Hounsfield unit is 1,200. It is not amenable for ESWL in stone strength-wise, but I have to make sure the other favorable factors as well, such as which case is, and I think it is in the renal pelvis, and
so the patient is having persistent pain requiring intervention. So
yeah.
Would you carry out CT-IVU with contrast?
Yes, CT. To see the any anatomical clarification, I can consider about CT-IVU as well, because of the persistent pain. In that case, I can plan flexible system URS rather than ESWL when it consider about when considering all the comorbidities and the anticoagulation therapy, which is the most safer in this situation.
Right. So what is your final surgical procedure you are going to use to remove the stone?
So considering the size and the Hounsfield unit and the location of the stone, it is 2 centimeter, and the hard stone. With the multiple comorbidities, I can try the flexi URS and rather than the ESWL. But in managing this patient, I have to optimize the patient. Probably we have to bridge the anticoagulation with the heparin therapy before surgery.
Okay. What are the advantages of doing a retrograde renal surgery in this situation?
There are first I will explain the procedures to the patient. There are 3 options actually: the ESW and the FlexURS and the PCNL. But when you consider about the PCNL, it is we have to puncture the kidney, and there may be a tendency to bleed. And as he is on anticoagulation, the risk is more than the normal population. But the FlexURS is we are going through the normal anatomical position, and the less likely to be injure the blood vessels and the bleeding. So in that case, I prefer for that procedure rather than the PCNL. But ESWL is not a good option.
Yeah,
it is very hard.
Yeah. Now, can you just describe the initial steps of FlexURS? Initial steps in a short, in very short.
Yes. First, I will do a cystourethropy to see any abnormalities in the urethra and the bladder, and then I will do a ureteroscopy, rigid ureteroscopy, and then I will insert the guide wire under X-ray guided, and then advance the ureteric sheath, and then I can advance the flexible ureteroscopy with the protecting guide wire. All the instrumentation should be under CM guided.
Right. Now, when you attempt to introduce the ureteroscope, it's very difficult to enter the ureter. In this situation, what are your options?
If we can't advance the sheath, then we can go through the direct visualization of the ureter and advance the ureteroscope under C-arm guided. And having a protecting guide wire is a most important thing. And then we can straighten the ureter, and that will facilitate the advancement of the flexi URS.
What is the value of pre-stenting and alpha blockers in this situation?
Yes, a pre-stenting, it has a value because it will dilate the ureter and it will paralyze the ureter for some time. Then the future instrumentation will be successful, and the stone clearance also very much higher after pre or pre-stenting.
Right. What is the value of access sheath in this patient? Do you use access sheath or not?
I will use the access sheath, but under C-arm guided, because it will protect the ureter as well as it protect the instrument when you are doing the procedure.
Any other special reasons for use access sheath in this patient?
There is a tendency to bleed in because of this on anticoagulation that will tamponade by the access sheath in the lower part. And apart from that, I'm not aware of any reason.
This is the relatively hard stone with 2 centimeter, and any other reason why access sheath is helpful?
I think very hard stones, and sometimes the stone can migrate to the various places, and when the stones can be mobilized, and sometimes we have to grasp the stone and retrieve. That will easy with the access sheath.
Okay. Right. What are the problems of using access sheaths?
The problem is actually it is a blind procedure, even though it is under C-arm guided. So it can traumatize the ureteric orifices and the lower part of the ureter. That's the main disadvantage of the ureteric access sheath. And sometimes if it is a long access sheath, it can reduce the maneuverability of the URs if it reaches the renal very close to the renal pelvis. And that's the main disadvantage of using access sheath.
What do you know about the sepsis, post-operative sepsis, if you use a access sheath or without access sheath? Are there any differences in sepsis rates? Is it the same?
I'm not quite sure, but I think if you use access sheath, there may be the better in sepsis rate because the drainage is very much higher rather than using doing a case without access sheath.
Right. Now, following surgery, what other precautions would you take in this patient?
Following the surgery, I have to most probably I have to put a stent in, and then we have to care about the stent as well. And post-operatively, I have to monitor the vital signs and observe for sepsis because it's a long stent.
Time's up.
Thank you, sir.
Suranga, I think you are okay, but there are small lapses in your knowledge, but it's really okay. Yeah. So this is a large stone.
Yeah.
Relatively large stone for a URS with a hard stone. So as you said, you have to use access sheet in this situation because there are multiple fragments and stone clearance. You need to see better, and it make little more time. So if your surgery is prolonged over 20 minutes, it's always better to use access sheet.
Yeah.
And sepsis wise, yes, when you use a access sheet, the sepsis complications are little less. And post-operatively, you have to use a stent because if you use access sheet, always it's better to put a stent because you can get edema and obstruction, that sort of thing. So I would put you 6. You
Okay,
pass.
yeah. Okay. Thank you. Thank you, sir.
Thank you, sir. I think Neville sir have one more question, but we will keep that for emergency urology viva, sir. Time is up, and we will ask Anuruddha sir's feedback as well. Sir, Anuruddha sir.
Thank you, Gobi. I think it's a very well conducted session. I hope all the trainees benefited, candidates. I think Professor Emil Perras and Namantha did a wonderful job. Thank you very much, actually. Perfect examiners. And even the candidates did very well. They have much better knowledge than me, Gobi, you know. And you have done a very good organization to make this event a success. Are there any other comments?
Thank you, sir. And I have to appreciate, the making these scenarios is not easy.
Yeah, exactly.
Even though Neville sir and Namanda sir is very busy, I can see, they have discussed with me and they have written the questions in the paper and send selected the images. It's not an easy job for the seniors and very busy people. We have to appreciate as candidates and as organizers. We are very happy that 2 senior people have contributed very well, and this will continue. And I think candidates have a responsibility to study well, and this is a teamwork. And we also are learning.
Yes.
This is not senior junior. We all are learning, and we want to make our society do very well in future. And so I think it's a good start. Neville sir and Namanda sir.
Yes. I think what I noticed was that, the knowledge-wise, our candidates are pretty good. Only thing is that I think the way they conduct the viva, I think they have to practice a little bit more and sound more mature. Like, giving evidence straight away with, as you mentioned at the beginning, these landmark studies and things like that, there are only about 10 or 12 you take everything together, stone disease and all the things. So these landmark papers, without hesitation, you must put it. So if it says that, let us say comparing URS to ESWL, this study says, that there's a meta-analysis to show that it is much better stone clearance when it comes to over 10 centimeter stone. Like that, just display your knowledge and the flow of communication. I think that has to be sort of without flows and without too much of pauses. Some of you all have to probably practice. So I think between yourselves, I think have these examinee sessions, and then that will, I think, cover up everything. So knowledge-wise, I'm sure you all are quite good. But when it comes to presenting it to an examiner, I think there is a little space for more improvement. All the very best, and we'll be sort of keeping an eye on these sessions, which are very valuable for you all for the forthcoming exam in March. And thank you, Balagobi, and then thank you all the organizers and Anuruddha for overlooking all the things. So I think this is the way forward.
Thank you, sir. Nandasena sir, do you have any additional comments, sir?
Okay, it's a very good session. I think we all benefited, and I want to thank all the organizing and the trainees who took part in this event. Thank you very much once again.
Thank you, sir. So the next session will be next Saturday, same time. Is in the pediatric urology. Dr. Sanjay Abegunasegar and Dr. Kanjana will co-chair it. If any change, we will let you know. So please get ready and study around the important topics in the pediatric urology. Thank you very much.
Gobi,
yes.
Excuse me. Thank you, Gobi and DSS. I have one question. For example, like 1.5 centimeter mid-polar stone. If the examiner asks what are the surgical options, do we have to consider shockwave? Is it a surgical option or just option?
I think you have to carefully listen to the question. So if I say surgical options, yes, but most of the time what I will ask is intervention. What sort of interventions are possible? In which case, even observation, not only ESWL observation, also will continue. But you should know at least a couple of studies to show that the observation, there are a number of these, I mean, there's no time to go through it. Probably I'll send you the answer script regarding, the evidence to show that in certain stones, observation is also good, and comparing ESW to URS and ESW to PDA. Yeah, you are right. If I say surgical options, so you start by answering saying that my surgical options are, so emphasize on that, and then you will escape without mentioning ESW, Shockwave Lithotripsy.
Thank you, sir.
I also have one question. The big stone Monipriya got for that question was anatrophic nephrolithotomy an expected question answer in that, or should we have?
In the era of endourology, we try to do minimal morbidity to the kidney and the patient and achieve maximum clearance. So in that sense, percutaneous nephrolithotomy with the multiple punctures or 1 or 2 second sessions, that is the way forward. I think open surgery, I mean, it's very minimal nowadays.
Okay.
Yeah, adding to that, if I may say, always before starting treating a large horn, always mention that I will assess the integrity of the parenchyma. Because if it is a dead parenchyma, we do all these things, because without a contrast X-ray, it's just a plain X-ray there. You say that I would assess it, and then if it is a salvageable kidney, I will go ahead with all these possibilities. I quite agree with Namanta. I think don't mention about void anatrophic nephrolithotomy and multiple nephrotomies. It's a resource poor situation, we can do it. So at the end, you might just mention saying that in resource poor situation where the facilities are not available, still combined nephropylolithotomy, open surgery is available, but it's hardly ever accepted nowadays.
Okay, so thank you, sir.
Thank you, everyone. So that's concludes our session. So we'll meet on next Saturday. Thanks, everyone. Thank you, sir, and thank you, candidates. Thank you.
Thank you very much.
Thank you.
Good night.
Thank you very much. Okay, good night.
Night.